we move to next speaker, Dr. Karan is the youngest dynamic surgeon. He will be speaking on MSICS in challenging cases. I request all speakers, as we have short of time, to stick to their timings. Thank you very much.
So I've changed a little bit because Dr. Deepak was covering the challenging cases. I just decided to focus on just one aspect of it, that is the big zonules. At the outset, I thank Dr. Nilutpanna ma'am for this opportunity and the chair for it. And it's always a pleasure, to speak in front of your mentor and teacher who handled my complications when I was a resident, Dr. Manasnath. So it's a pleasure to speak in front of you, and I hope I can do justice to the topic. So a preoperative workup in such cases is extremely critical. You need to look for phacogenesis in the undilated pupil. On dilatation, look for flattening of the lens periphery and look for predisposing conditions that are pseudoexfoliation and trauma. If there's vitreous in the anterior chamber, you need to do vitrectomy first and then go ahead with the lens management. A pars plana approach is also sometimes you can go ahead even for anterior segment surgeons. So intraoperatively, be always prepared for any complication and keep your handy tools such as the CTR, the Sioneering or the CTS in hand or ready. So capsular staining is extremely important here, but it's dubious also because it toughens the capsule, but at the same time, the dye can escape to the vitreous cavity, particularly through these areas of zonular dialysis or coloboma eyes such as this. CCC is often the first indicator. It's more effortful. You can see this shakiness of the lens that is this in such cases. You can see the lens is moving, and this is when you get an idea that, this is better to do an SICS, or you need to do something, plan as if you're doing a phaco, but SICS becomes easy here. So it's always better to shift to a rhexis forceps because it puts lesser pressure on the zonules. This is another case. It's a coloboma eye. You can see finding it a little bit difficult, but it's always better you shift to a utrata or a micro rhexis forceps, and because it makes life much more easier. In such cases, you have to center it on the lens, the rhexis. Look at this case now. Now this is a case with a coloboma, a grade 5 cataract. There's calcification on the anterior lens capsule. It's very difficult to cut the capsule. I tried this with the cystitome. I tried this with the Vana scissors. Eventually I had to go with the micro scissors. Now this is where the real advantage of SICS comes in. Phaco would have been so difficult in such a case. So cut with the micro scissors, all this, and then you can easily remove the lens without, because you need to do minimum manipulation in any surgery that you can do. So coming to a CTR implantation, I'm saying as early as possible and as late as possible, because if you're finding it difficulty, you put it early like I'm putting it here. But if you can delay it, you can see there's an area of zonular dialysis, then it becomes much more easy. Particularly cortex aspiration can be slightly difficult when a CTR is already in place. So using the two-hand technique, you have to go in, first put it inside and then use two Sinskey hooks so that it doesn't slip away. Similarly, another eye of coloboma. This is another eye. So again, I'll say as early as possible and as late as possible, you have to take the call. So the real advantage of SICS is actually the nucleus management. So you can see this is the area of the zonal dialysis. I've shown the previous steps of these two cases. The lens slightly rotated, but then I could go ahead with the Vectis and take it out. And the second video, if you see such hard cataract, doing a phaco would really be turbulent through the endothelium. Also in such a case, you can have a bag, you can eat up the bag also, so it's always better to do an SICS, particularly when the rhexis is compromised. The IL insertion, you can go ahead with the routine fashion. In such cases, if you're putting it in the bag, the haptics should be oriented towards the area of zonular dialysis, but if you're putting in the sulcus, you can put it 90 degrees away to it, and then you can do an optic capture. A 3-piece IL is definitely recommended over here. In case of absent capsular support, again you need to know how to make a tunnel. So iris claw IOLs is a very handy tool. It really does help in situations, and you don't have to have a VR all the time. This is another technique that we developed called the MYX technique, and we published this. So in cases where, so this has good iris, if in cases where the iris is not sufficient, you can do this sutureless technique for SFIL, and it's also got the IGO Silver Medal Award for it. So it's a combination of Yamane and the XNIT techniques, and then you create a flange and this buries intrasclerally. So I'd conclude by saying SICS is the backbone of all eye surgeries, and it makes difficult situations easier to handle. Thank you so much. At the outset, I'd like to invite all of you all to the Young Ophthalmologist meeting that we are having in Delhi, Indian Habitat Center from 27 to 28 April. Please register for it because the early bird registration closes in 2 days. Thank you.
Thank you. Thank you, Dr. Karan, for reciting the